Good afternoon. I'm Dr. Maura Wren, Chair of the Duke Psychiatry and Behavioral Sciences, and I want to thank you for joining us. I'm delighted to introduce today's guests, Dr. Damon Tweedy and Dr. Julie Pensner. We want to leave as much time as possible for what promises to be a rich conversation, so I'm going to keep my introduction brief. Dr. Tweedy will be talking with Dr. Pensner about the urgent need to center mental health in medicine, the topic of his new book, Facing the Unseen, which will be out officially tomorrow. Dr. Tweedy is a professor of psychiatry and behavioral sciences here at Duke and a physician at the Durham VA healthcare system. He's also alumnus of the Duke University School of Medicine and the Duke Psychiatry Residency Program. Dr. Tweedy's first book, Black Man in a White Coat, published in 2015, was a New York Times bestseller. He has also published articles about race, medicine, and mental health in medical journals and media outlets such as the New York Times and Washington Post. Dr. Julie Pensner is the Vice Chair of Education at Duke Psychiatry Behavioral Sciences, as well as the Associate Director of Psychiatry Residency and Director of the Undergraduate Medical Education in Psychiatry at Duke. Please join me in welcoming Dr. Tweedy and Dr. Pensner. Thank you.
Before you jump in, I just want to say thank you, everyone, for coming. Obviously, there's so many, competing demands. There's this eclipse thing going on today, right? It's funny. I didn't even know about it a couple of days ago, but whereas my son was knew all about it. It's just so interesting how we're in the same house. Why don't you tell me? But anyway, thanks everyone for coming. I know you many things you guys can do with your time, so I take that seriously. So thank you so much.
I also want to thank everyone for coming. But I also want to thank you. It is a wonderful, wonderful book. And I had the chance to read the advanced copy. So I'm telling you, it is a wonderful book. And I'm really excited, Damon, to get to talk to you about it and to hear some more about your process. You and I know each other through the Psychiatry Student Interest Group, which is a wonderful, vibrant group. I love it. Your leadership is steady. There's always a lot of students. They have tremendous enthusiasm for psychiatry. And I have to admit that in the few times that I've, come and met with them or attended, I took your interest in psychiatry as a given and as a thing that showed up for you very naturally. And I'd like to share with our friends that that's false. Let me quote Dr. Tweedy. Dr. Tweedy writes, "Nothing in medical school changed my perceptions of psychiatry and mental illness. In fact, it only solidified them. Many physicians I sought to emulate had little respect for psychiatrists, and some had a seething disdain towards patients diagnosed as mentally ill. My required psychiatry rotation was an epic failure if the goal was to humanize both sides. And most succinctly, all I knew about psychiatry on day one, this is page 29, was that I wanted absolutely no part of it." So I think, Damon, if you wouldn't mind, if you could rewind the tape a little bit, tell us about the origins first of your distance from psychiatry.
Yeah, so I'm like the psych interest group, right? So I'm like the last, sometimes I step back, I'm the last person that I would imagine being the person that sort of encouraged medical students to go into psychiatry. Just so if you go back to how I started. I guess it's a couple things. I think if we think about it honestly, I came to med school with thinking about cardiology, orthopedic surgery, very sort of what I thought were concrete kind of, nuts and bolts kind of disciplines. And there's also there wasn't any sort of preformed negativity towards it. Orthopedic surgeons help people who have knee problems and heart doctors help people who have heart attacks. It all seems but you think about mental health, I feel like without even knowing it, I kind of came to medical school with sort of preformed or preconceptions about what it meant for people to have mental illness. You think about people who are homeless and, and you think about people who've been incarcerated and there's all these different, or maybe someone in your family or have family members have alcohol related problems. And it's there's all this sort of negativity that's sort of in there before you even step foot into the world. And it's I didn't really, it was subconscious. It wasn't something I was really aware of until I got into medical school. In that first year of medical school, the clerkship in medical school, I think the issue is that, so first of all, my surgery rotation was here, my medicine rotation was here, OBGYN. The psych rotation was away. It was at a separate place, it was at a separate location, 20, 30 minutes away. It's well, why is it that? Why am I going to this separate place? And over there, there's prison over there, and there's detention center. It's what does all that mean? It's kind of people say, well, be careful, don't wear a tie, don't do this, don't turn your back. It's all these things that sort of make it seem like it's a scary thing. And so when I got to the rotation, as I mentioned in the book, a lot of people do, were sort of down on psychiatry like in other departments. When I got into the rotation, it also just didn't, it felt so odd and it was so different. And it was like I couldn't make sense of like how different it was than the rest of medical school. And the patients seemed isolated, and I struggled with that. And I mentioned there that I didn't want psychiatry, but it felt like psychiatry didn't want me either. I'll tell you a quick example of that. So at the end of the rotation, this didn't make it into the book, but it's an interesting story. How unlikely it is that I'm a psychiatrist. At the end of that rotation, we had to do what, maybe you probably know this. You do an oral exam where you interview a patient you've never met before, and you do it in front of a psychiatrist who you've also not met. So it's like someone on the ward they bring down, and you interview, and you're supposed to do 30 minutes to figure out their everything, right? You probably had something like that, right? And you're supposed to figure everything out. And so in this interview, this patient was talking very slowly. And I was, as you can tell, I talk very fast. And it was like this sort of contrast. And I had 30 minutes. I kept looking at my clock. I got to get this information. I got to get everything done, or else I'm going to do poorly in this exam for this guy who doesn't know me. And so I was cutting him off, finishing his sentences for him. Well, you really mean this, that sort of thing, very checklist oriented. And you can imagine that didn't probably go so well. And at the end of the session, the faculty member said, well, tell me what you want to do in life, which is probably like a not great question. Like, tell me what you want to do in life. And I said, well, orthopedic surgery, cardiology, those are what I'm really interested in. He's like, yeah, those are good fields. And, but even if you go in those fields, you still have to like talk to patients. And, and based on what I'm seeing, I'm not so sure about that. And I wonder if maybe you try to do this with a sort of like psychiatrist sort of way. I wonder if maybe you should consider, pathology or research and, you want to see patients. And so, wow, and so that was actually psychiatry is actually the rotation I got the lowest evaluation on all through medical school. And so it's such an irony that, that I'm here today. It's something like the most unlikely psychiatrist you could imagine. One other thing I'll say before we move on is that, I come from a family and a community. I think I should just kind of put this out there. So first of all, when someone, sees me, right, they're probably not seeing doctor at all, right? If you think about my younger self, they're not seeing that in most cases. Certainly not seeing psychiatrists. In my family that I grew up in, I grew up in a working class Black community. Mental illness wasn't like something that people ever really conceived of as something that's actually a real thing. People might have stress, they may have, like, my grandmother would say, well, people have a certain way about them. That was her way of saying, something's not quite right, but it was never like conceived of in any other way beyond that. And that my grandmother was the person who would she would pace. She was like a chain smoker, pace around. And when people would, one time a friend told her that she was too stressed out and maybe needed to like kind of chill a little bit. She's like, well, I grew up she had a really tough story. She grew up in the Jim Crow era. Her dad died when she was very young. Her husband left her. She raised 3 children by herself. She had a hard life. And so for her, it was all kind of like, this is just part of this. I'm a strong Black woman, and this is what this is the cross I have to bear. I had an aunt, one of her daughters, who's also struggled, in ways that, again, weren't framed as mental health issues, but she was like, she was kind of, she'd be prone to being reclusive at times. She would get really, she'd have these spells where she'd kind of get really upset. But again, we just framed it as this is just her personality, right? It was just sort of a way about her. It was only when she got much older that, that it became more that she was actually something that she could go see a doctor or a psychiatrist to actually talk about. So that's kind of where I grew up in. We had a neighbor also was kind of, had sort of unusual traits, but people never framed it that way. And when I started to think about psychiatry, like even in med school, like you might, if you have it, probably might go to your pastor, you might go to someone in your church to talk to, but never some stranger. Like, why would you, on earth would you do that? I know it's not just unique to Black culture, but I'm just saying there's definitely a big part of that was how I grew up. And so when I told them I was going to psychiatry, they were like, what? And so, but here I am. So, now I've sort of done this 180, and hopefully we'll talk about what that's all about.
Yeah.
A lot, right?
Listening really carefully, because what I love is that there are as many journeys to psychiatry as there are psychiatrists.
Mm-hmm.
And it wasn't on your radar.
Not at all.
We didn't help it along in terms of fostering your interest for it. You shared with the group that you maybe didn't exactly take to it instantly.
Understatement.
There, you psychiatry.
Right. Right.
So tell us about that and walk us through the pivot.
Yeah, it's like it wasn't like there was a magical moment, but I went in internal medicine because I thought that you do that's like the prelude to go into cardiology, which is still what I was thinking I was going to do when I entered, medical school and then throughout medical school. I just really loved EKGs. This is I don't know what to say. It's such a strange thing to like. I had a sort of affinity had an aptitude for it, and I just liked it, and the numbers. I was a kind of a math immersed person. I really liked the whole EKG thing. Chris is like, I don't get it. Sometimes I don't either, but I really like this. I really had a feeling for cardiology. And, but one thing that as I got into the field was moving more towards like this, it was been moving more towards like catheterizations and ablations and more sort of procedural sort of thing. And I really like the sort of the kind of cerebral EKGs, reading echo, more the cerebral and then sort of the finer points of like the auscultation, and I really was into it on that level. And so the field was moving more and more away from that. So that was one sort of thing that I was thinking about. But that doesn't mean I would go into psychiatry, right? So why psychiatry? It's funny. So in med school, again, that rotation was really, was not good as I discussed. But during my third year, I worked in a lab mostly with cardiologists, but there also were psychologists embedded in the lab, and it was looking at like, sort of like medical medicine treatments for like hypertension and stress and mental health. And it stress was really I was still thinking about it from the cardiology frame, but I got to work with some psychologists, Dr. James Blumenthal, he's listening, thumbs up. It was a good experience. And it really kind of helped me think a little bit differently, that I knew there was this mental health thing and there was this physical health thing. Personally, I had high blood pressure diagnosed in medical school. And this lab was like a way to sort of thinking about how do you sort of use them, beyond just medicines, what other ways can the mental health aspect contribute to it? And so that was the beginnings of me thinking about it a little differently, but it's still no chance I was going to go into psychiatry. But internship year is kind of where everything kind of really changed. And during that internship year, there were probably like a couple things that happened. One is that cardiology was something that I was getting less interested in a little bit based on the field itself and where it was headed. But then also one day I was going down to the ER, as a medicine intern, and you had to like clear somebody. This is someone who's coming in acting, as having some sort of behavioral issue, and you're supposed to clear them from the medical side to make sure they can go safe to go to the mental health side. And I went down there, and it was looked in there. It was someone that I actually recognized, and I just like stopped dead in my tracks. And it was like this sort of disconnect. Like, hold on, what's happening here? How could this person be this person? This is someone I'd known from years previously. We had played basketball together, and I kind of knew him. And it was like dead in my tracks because I had this us versus them. I think we'll talk more about that hopefully. But I think that's what drives a lot of the problems we have with how we see mental health in our world. We can sort of see them as people who are distant from us, right? Homeless person, different. Person in prison, different. Person who has alcohol or drug problems, different. None of those issues impact me. Like me personally, my wife might say differently, but I feel like I'm relatively, don't have any of those sort of issues. And so it just feels like an us versus them kind of thing. And to see someone that I actually had known as a us, and then now was a them, I know that seems so like silly to you maybe in the audience, but it was like just mind blowing. It's like just sort of disconnect and dissonance. And it was just like, it was eye opening. And then as I started to continue my medical, internship, and I would see patients coming in, I began to sort of get more interested and attracted to this idea that, okay, what is this person's kind of story, right? Like I might see them in this moment here, but then like I saw like several like graduate students who come in with different types of problems and other things like that. So there was an initial connection I could make to them, but there was also this idea that they had this severe mental health problem. And it began to open my eyes to a different way of thinking about mental illness that I just had never envisioned. Because again, I think we were indoctrinated in med school to sort of think about it as us versus them. I feel like it was a kind of indoctrination in some way. At least that's how I felt. And so it was eye-opening to see that. I would say that was probably the most seminal thing. But then there were other things as well. There is this perception, of course, that psychiatry, I think I just got to confront this head on. There's this perception, of course, that psychiatry, like not, real medicine, not real doctors, huge perception like that. And so one day in the ER, I walk in the ER, another time in the ER, blocking staff, everything happens in the ER. And I went in there, and there's this woman who was, basically, you guys know that basically she was like frozen, couldn't talk, wasn't moving, has catatonia, but didn't really, the ER medical team didn't really know what was going on because her blood pressure was really high, her heart rate was through the roof, and they had no idea what was going on. I was on the medicine team, and they were going to admit her, going to do LP and all this sorts of stuff. And then a psychiatry resident comes in, and the reason why they called the psychiatrist was only because at that time Duke had separate like medical records. And so it was completely separate. Like you could not see the record at all. And so they would call it a psychiatry resident so they could actually look at the that's a whole separate issue. And so they could actually look at the records just to know what was going on with her, because they had no access to the. I mean, it's just like mind-boggling. Think about how we set these things up, and that was the issue. So they call it, and then the psych resident comes in and says, "Oh, she's got catatonia. You need to give her this, this drug." And they're like, "What are you talking about?" It was like that kind of thing. They were really skeptical. But they, he was really saying, "Well, call my attention if you don't believe me, et cetera, et cetera." He was a pretty confident guy, and he was right. And it was an amazing thing to sort of see that how untreated this could have gotten bad. Her blood pressure was through the roof, her heart was through the roof. It could have been really bad. And it's like, wow, I could see psychiatry in a different way. And so there was that moment there, but there was also the reality that there were these, this sort of dissonance between with my friends. So those are the things that really kind of made me think more about psychiatry. But it was still really hard to actually make that decision. It was so hard. I remember talking to this one faculty member, med psych attending, and one of your colleagues, and I went in there, and it was like, because after this patient we talked about, and I was like, I closed the door. And I was like, this thing's kind of interesting. Is a lot of cases like this? And she's like, "Are you interested in psychiatry?" I was like, "No, I can't say that." And so there was all this like push and pull, because there'd been so much welled up in me to be against it, right? And because of everything I told you that led up to it, my family, my community, the medical system, and it's like, wow, am I gonna give up all this stuff, this orthopedic surgery, cardiology thing, and do this other thing? It was such a hard thing to do in that moment. But so then, one day I just kind of got tired of that, just kind of said, pull the plug, and here we are.
Pulled the plug, so to speak.
Bad analogy, right? Yeah. So, my words are, yeah, you know what I'm saying. Yeah. I was gonna say pull the trigger, but that's even worse. So yeah, worse. Exactly. We gotta find something better. Yeah. Anyway.
I can feel the shame in it as you talk about it, and I don't know.
Crazy.
It is.
Yeah, it is crazy, right?
I don't know if we're the us or the them, but when you left them and you moved to us, how bad was it, right? I mean, what was it like? You had to tell everybody, you had to deal with it. How'd you do it? And how long did
Right. So yeah. No, so it was actually great. Actually it was like a relief, and it was actually great once I kind of got into it, and realized but it's still a challenge. But initially you were still working like in hospitals, so it's still very much like the kind of, it's not that different in some ways. But yeah, it was a big change. But great, it went well. And I'm here.
So you're telling the story in part as a motivator for a very important message in your book. Can you tell us about the book, right? What's it about? Why did you decide to write it now? How does this story get to you?
Yeah, actually, so after that first book I wrote, I kind of thought I was done, not kind of one and done. I wanted to write more. I was like, just maybe that's past and moved on. But then one day I was in with some med students, actually, a couple med students I see in the back there, and I was sitting in a Zoom call, and put them on the spot. It was a Zoom call. This is like during COVID, and we were going around. There's like 15 students, and maybe I should press more about that, because the context of the course is kind of like psychiatry for the non-psychiatrists. That's sort of the goals. Because the reality is that 95% of doctors are not going to go into psychiatry. People go to med school, but as I mentioned earlier, my med school experience was so limited. It was only inpatient, it was only acute care, it was only crisis oriented, and that was it. And you think about, like, my wife is a general medicine, internal medicine doctor, and so about a third of the people she sees have mental health, or maybe more, mental health issues. But her only training in psychiatry was as a med student in an inpatient ward, and she had no other experience, like in residency, like zero experience as a resident. And yet she's being sort of tasked to sort of manage all these mental health issues. And it just seemed like that doesn't make any sense if we step back and think about it. And so part of this goal is, Dr. Shelley Homer, we sort of work with the family medicine department and have a course designed to have students who are not going to be psychiatrists kind of learn something a little bit more, like some of the other aspects of psychiatry beyond just sort of the acute crisis, mode of psychiatry, which is important, but there's more to it than that. And so this course, I've been doing this course for years now. And one day we were just, in the Zoom boxes, and this is how we've known each other for a long time initially. And students, they were going in the room and they were describing these clinical scenarios where they were on these different medical services, and it felt like the patients weren't getting their needs met at all in terms of mental health problems. So they would be in a clinic where a person has, cancer-related issues, they're smoking. The doctors never talk about smoking cessation. You could just kind of go down the list, like not talking about anything related to mental health. Yet these are really important issues, and so the students themselves seem to be more attuned to what was going on in some ways, or maybe had more urgency about it than the faculty. And it felt like there was this kind of huge disconnect, and it reminded me of like, how do we get here, right? And it made me look back on my own experience, and because a lot of these doctors that we're talking about were sort of trained in my own space, and I think that's what really made me think about this topic. Like there was an urgency to it, like because it wasn't just like something in the past; it was still happening in the present, and patients were still suffering. And so that's kind of really what kind of led me to this story. And I feel like as me, as someone who's on the other side, who kind of knows what it's like to think that other way, that maybe I had a little something to say, and hopefully could bring in people on that other side to think about it a little bit differently, because I can kind of connect with where they're coming from as well. So that's sort of how it kind of all really came to pass. So the book is really about, how do we center the sort of mental health issue within the sort of, the broader framework of medicine. What are the ways we can do that? How do we make it better?
You mentioned the Zoom room as part of where you started to have the origins of these ideas. How did the pandemic affect the process?
Oh, you mean in what way?
For many, I think it has really accelerated our recognition of problems in
Right. Right.
the mental health phase of the pandemic right now, as phase earlier. How did this affect your need to tell this story and your hypothesis about centering?
Yeah. I mean, I think the pandemic obviously accelerated problems. It also made things more visible that were already there. So the problems were already kind of there. The access to care, the problems were, the increasing rates of mental health issues were preceding the pandemic. Drug use, overdose, all sorts of things. But the pandemic kind of just accentuated it. It also accelerated as well. And the number of consults just like doubled, almost felt like almost overnight. I mean, once like a few months into it, it's just been, and it's just like, it just highlighted the problems that we had, I think, in so many ways. And I agree with you. I mean, COVID is like, right, it's a great example. COVID is an infectious disease, right? COVID-19. But there's also this idea of like, it's also more than that, right? And so there's this medical quote side to it, but there's also this huge, tremendous sort of psychological aspects to it that I think initially were underestimated, but have been still with us today. So I think it's a great example of how you can't separate the physical and mental in the way that we've done in medicine. It's all sort of interrelated.
So the hypothesis that I read and I hear you saying is that, and I agree with, frankly, that if we do better at centering mental health care in medicine or in primary care, we'll meet patients where they are a little bit more deeply. Can you elaborate on what you view as some of the benefits, but also what are some of the trade-offs?
Yeah. I don't think it's necessarily just primary care. I think any area of medicine probably needs like a layer. As one guy I've talked to who's in family medicine in another university said, there needs to be like a layer of like mental health, basically in all areas of medicine. That's not going to mean we don't always need psychiatrists to do the specialty work. It's not going to like threaten our job security. There always be. I mean, I think that's one of the things that people think of as like barriers, right? People are like, well, this is like I have a certain traditional way of doing things, and this might be my turf that you might be interfering with, but there will always be a need for that, right? Unfortunately, in some ways. But I think that we need benefits. So like, for instance, at the VA, I've been to the VA for many, many years as part-time. And part of that whole thing with the VA, I guess I'll just sort of digress a little bit, but I'll get back to why it's important. So the VA for me is really important personally because my grandfather was in World War I, a long time ago. I had 2 or 3 uncles in World War II, uncle in Korean War. My dad was in the Navy between Vietnam and Korean War, between Korea and Vietnam War. I had a couple uncles who really struggled, alcohol-related issues. One was homeless, died in the VA. My dad went there and said he would never go to VA ever based on that experience. So it was kind of like a deeply personal connection to the VA in terms of like my family and their history, and knowing that. So one thing, so at the end of residency in 2007, Richard Weiner gives me a call. Some of you guys know him. Rich Weiner says, we got this new program at the VA where they're trying to integrate mental health into primary care. And we know you start out in internal medicine. You're probably interested in the medical stuff. What do you think about this? And it was really great. Best thing I ever did. Because it's actually was in some ways, people think of the VA sometimes as being kind of behind, one or two steps behind places like Duke and private world. That's certainly a perception, but in this case, it was actually ahead. They were integrating, mental health into the primary care setting, and at its best, what it does is it really, the advantages, right? At its best, what it really does is it really brings, it kind of disarms this idea that they're two separate things, right? The traditional model is patient comes into a medical setting, mental health referral. You're saying I'm crazy. You're saying I'm going to a different building, sort of thing, different floor, and saying, well, right down the hall, there's someone who can talk to you about this issue. Kind of makes it seem like it's not so different in some ways, right? So I think that's it's immediate, and again, at its best, it's immediate. It sort of demystifies the idea that they're separate. I think it's also good for the providers in some ways, because I think we work in silos, and you can be at a place like here, and you can not see someone for ages who's in another department, right? It's totally separate. And then when you get isolated, you start to think about the people in the other discipline in ways that are maybe, these neurologists are this way, and these gastroenterologists are this way, and these psychiatrists. You get back into your silos. The idea that you can actually work with people and see them in different fields, you can get a better appreciation for their own challenges, and they can get a better appreciation for yours. So I think that at its best, it really works well in that sort of way. So I think those are the advantages, right? Disadvantages are like system-based issues, like who's going to pay for it, all these other sort of challenges like that. Doing something different is always hard for everybody, right? So those are the sort of challenges.
I'm listening carefully to what you're saying, and I hear you mention geography as incredibly fundamental, right? Education in psychiatry was a site. The first time you started to think about it was the embedded psychologist model in criminology. You write beautifully about a number of patients where it was easier for them to come see you because of the co-location. So yes, right? Awesome. What do we need to do educationally to help the students start to bring this along, or are we already doing that, right?
I think we're making progress. Just to sort of cut to the chase. I think again, my med school rotation, again, it's a separate location. You're seeing people at their most distressed, their most vulnerable. I mean, it's important. I mean, people need the best care possible, but that's just kind of one way of thinking about mental illness. It's an important way, obviously, and I'm not minimizing that. But if you only see someone in that way, if you only see someone with X diagnosis, you only see someone who has alcohol-related problems when they're intoxicated or when they're withdrawing. You only see someone who has, whatever, schizophrenia, you can name the illness in the worst state. You can get yourself tuned and think, well, that's what everyone is like who has these problems, and they don't get better, and they just kind of keep coming back, and I don't want to deal with that. And I think that's very much because I got too much else to do. And that's very much the sort of medical model that we are educated under. And so how do we sort of get out of that, right? So it's important to know all those things and work in those settings, but you also need to see people doing better. So if someone has alcohol problem, maybe you can work in a setting where you see people who are in recovery, who are doing well. And it's like, okay, well, I see this person in this spectrum, but then I know that there's a continuum of problems. Or if I see someone, like even with schizophrenia, right, we think, oh, that's the worst thing that could happen to someone, sort of thing, right? So in this class I do with these medical students, I mean, we go to this, so yeah, you work in the hospital, you see that, you need to know that, but we also take them to this like a threshold, it's like a clubhouse. They get to see people with SMI, severe mental illness, functioning in a different way, like learning vocational skills and community and socializing and things like that. That's an amazing thing for them to see. So I had one student some years ago. He actually, when we went to this place, he actually had seen this woman on his inpatient rotation, and then he saw her in this setting, and he wrote the most remarkable essay about it. He was just it was like eye-opening, mind-blowing for him. This person could be this other person. It could be the same person, right? I think that's just such an important opportunity for us to expose people to the full spectrum and understand that it's a continuum. It's not just this one thing. It's not just one crisis moment. That's true for other areas of medicine. It's not just psychiatry, right? So imagine if you're like an OBGYN, and the traditional model is you see woman when she's pregnant, And then so it's almost like a collision, right? It's like you're colliding in time. This person's in crisis, and then you see them and you're on duty, and you just happen to see this person. And then you see her for a delivery, and then maybe the next day you see her at postpartum, and it's like, well, then it's like, have a good life. And that's it, right? And I mean, it's important to know that model, but what if you saw that person when they were pregnant at 16 weeks, and maybe you saw them a couple of times later, and then you saw the delivery, and maybe you saw them 6 weeks postpartum. I mean, think about how different you might conceive of a person and thinking about their delivery if you see them in that full spectrum. And I think it's true for psychiatry. I think that's the challenge: is how do we incorporate other ways of seeing people other than just in that sort of most vulnerable crisis moment. I think that's a challenge for us to think about. I think that will make people think about it differently. It'll also give the doctors maybe hope. Like if you're a cardiologist or endocrinologist and you're seeing people who have diabetes and they maybe they need to improve their diet, they need to stop smoking, whatever may be the case. In med school, you're kind of conditioned to think of those people as people who those problems can't really be addressed, or they got to do it on their own. But what if you worked in a setting where you're in medical school and you've gotten to see people get better doing those sort of things, and imagine how that might then transfer then when you're in practice. You say, oh well, I can draw on the fact that I work in a smoking clinic. I saw people get better from smoking. Maybe I can talk to this person about this because I learned that skill in medical school or in residency. I think that's how we need to think about kind of reforming education. So something's happening. So med schools have this kind of like more of an outpatient, longitudinal curriculum kind of beginning to be built into it. I know there's challenges. It's a lot harder to do that, but I think that's where we kind of need to be thinking about if we're going to really make progress.
Do you think that, yes, but do you think that more people will choose psychiatry? Or do you think maybe it doesn't matter if they have more hope about psychiatry because they want to choose a place?
I feel like I'm going to get in trouble here. The chair of psychiatry is here. Education is here. I think I'm about to get in trouble here. I don't want to get excommunicated, right? Yeah. Because right at this point now, I can't read EKGs as well, so I would. So I have to stay. I can't go back at this point. It's too late. I think again, there's always going to be a need for psychiatrists. That's never going to change. That's not going to go away. So I don't feel like there's a job security issue. I do think there's actually an uptick of people going into psychiatry. I think that's probably because there's younger people have more experience with, like. I'm going to get back to your question, but I do a second year group of second year medical students. There's like 8 students in a group every year, and it's like a kind of clinical skills foundation. It's called CSF2. They're like learning more doctor patient kind of stuff, right? And so a couple years back, a couple of students were telling me that it's mostly about the second year, how hard it is. Second year med school is tough. You're doing all these rotations, new site, new location. Actually, other than the intern year, it's probably the hardest year. It's really hard. And so a lot of it's just sort of supporting the students through that year. And a couple of students were telling me that they had gone to see a therapist during the year and how that was helpful. And they were very open about it and transparent about it. And these are not students going some kind of surgical field, and one's going some other sort of very subspecialized field. So not like people going in psychiatry, but nonetheless very attuned to how important this issue was. That also was like, wow, because I remember my group, and if I would have told someone that I was going to see a therapist, like that's like something, I'm weak or something's wrong with me. I mean, that was the culture, and so I mean, very much the way it would have felt. Can I tell that story about that when that happened with when I went to the? You mind if I? Yeah. Let me tell you. So I consider myself. Again, my wife might disagree with my kids. I consider myself psychologically, pretty healthy in general. Generally optimistic and stuff like that. And I didn't have any issues like growing up. Yes, even you say, well, as a Black person, it was hard, obviously, but in some ways you didn't realize it because you had the community with you, supporting you along the way. So yeah, I had people, all kinds of racist things that I could talk about, but that's not the point here. Ultimately, I still feel like I had a pretty good, sense of self, if I can put it that way. I might have cried a couple times in my life. So I cried like, after I got out of being a small kid. In high school, we lost our playoff game in basketball, and I missed the shot at the end and could have won. You see those people on TV, right? You see how that's tough because people are like, well, how are they crying? It's hard if you put all your time into something and it just doesn't quite come the way you want it. So I cried in that game. That was so hard. Boy, it was hard. And then I don't want to minimize, but it really was. But then my grandmother died when I was a first year medical student. And so I talk about her in both books, and she was the only grandparent I really knew, and that was hard. And so I cried then. That's about it. I mean, that's it, you know. So I'm like, I'm not trying to make it like it's a problem crying. I'm just saying that that's sort of how I kind of framed my life. I thought I was doing fine. Internship with the year was really hard, but I was doing well. You know, I was plugging along. You know, I was doing okay. And then I'd already made the decision to go into psychiatry. And so I just had 3 months left of medicine. So I had to do like a oncology and another medicine rotation. And I was going to be home free, going to psychiatry. Everything's fine. I've got through the worst of internship year. But something happened. So, and it's one day. And I think it's important because it helps this idea of like, how do we get to this place? So one day, the ER is always a place, right? All roads lead to the ER. And so it was I don't know what happened that day, but it was like the busiest day they'd had it on record almost. And it was just like, we got like 6 admissions before like lunchtime. It was just like constant. And that night, and I mean, I was doing fine. Again, I kind of got into it. I was like 9 months into it. But that night, I had to do something called a paracentesis on someone, where you have to drain abdominal fluid from someone. Um, I gotten pretty good at the procedure thing. I actually kind of liked it. I was got good at drawing blood on people and putting in lines, and I was really good at that sort of stuff. That's why people are like, why are you going to psychiatry? People would say that to me because I had a sort of affinity for it. But this one night, I could not get this fluid off this guy, and and I went in there, tried it, and then I tried again, and then I cursed. And then the resident's like, "Oh, you can't do that. What's wrong with you, right? You know, this isn't like anesthesia. If the person's not under, right? You know, they're awake. You can't do that." And then he's like, "Well, you know, just." And then after I tried it, he said, I'll just take care of it. You know, just kind of go back to the room and work on other patients." And I don't know what happened, but at that moment, it's like everything had just hit me like a ton of bricks. It was like this idea that I somehow failed. You know, we were in medicine. We're so like we got to do everything right. You're sort of indoctrinated. It's like I'd failed, and I walked into the room with a medical student, and everything just fell apart. So I took a clipboard and like threw it across the room, and I just started. You know, it was just me and him. I didn't throw it to anybody. It was a clipboard, and I threw it. This is like so out of character for me, and I like started cursing again, not in my character in this way. And I was like, oh my God, I can't believe I just did that. And this was a medical student right here, and the medical student was the one who was like comforting me. He's like, "Oh, it's okay. You know, my sister is a resident as well, and I know how hard this is." So it's like this is backwards. He's comforting me. I'm the one supposed to be doing the opposite. And then it was like, I can't believe this happened to me. And then I was like, oh my gosh, people are going to know this happened to me, sort of thing. And so I went into the chief resident's office the next morning after the call, and I told him what happened. And I was thinking, this is how funny it is. I was thinking, okay, he's going to tell me that I need to do more procedures to get my technical competence down. I'm still thinking in that frame of my mind. And he's like, I'm a little concerned about you. And I was like, whoa, what's he talking about, right? And I feel like, so maybe you should talk to someone. We have this resource. I never, ever, 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 ever seen anybody, right, ever at any point in this kind of way. And I'm a person thinks myself as psychologically normal, quote, and he's telling me maybe I'm not in this moment. And it's just like, wow, I can't believe this just happened. And I feel like then the more I started to protest, the more he might think there was, it's like, that whole sort of cycle. I protest too much, that, it's going to be even worse. And so the nuts and bolts of that was that I had to then go to like this sort of like mandated evaluation, right, by like some sort of employee assistance kind of thing, before you could return to work. And it was like the most amazing. It was eye-opening because again, I'd never been in that experience before. I was so like, you talk about the word shame, right? So I remember walking into that building and like putting a thing over my head, like a hoodie over my head. But then I thought, okay, I'm a big tall black guy. If I do that, I might have other problems. So let me take this thing off. And just sort of just kind of shoot, and sort of just make this thing work. And but I went in there. And I remember even in the waiting room, I was like looking around. I was like, God, is someone gonna know me here? It's like all this idea, like there's something so bad. Like it's like this idea that I had done something wrong and that I was a bad person. And I think so many people feel that way, and it gave me such a experience of feeling that way. Because if I had like gosh, if I had an appendicitis, I wouldn't feel like. I mean, if I did do something wrong, I still wouldn't think about it in that same sort of way. And it was amazing to think about. And I went in this room and I talked with this guy. For now, and I was worried. I was like, because this guy has power over me now. You can think about what patients might think when you go see them. Is this guy going to take my job from me? Is this guy going to do this? Am I going to be able to come back? I worked so hard to get to this place. Can it all just be gone just like that in one moment? And so you think about the vulnerability people come into when that space. And so that was really an eye-opening experience. It really helped me really understand, what people we see experience in the most powerful way. So where were we with that? Why did I brought it up? But it was such a powerful thing. Yeah, what was your question, by the way? But yeah,
Listening to you, Damon, and I'm just thinking about how hard medical training is.
yeah, it was brutal.
Just learn how to be non-judgmental.
Yeah.
And
Yes.
you guys go through it.
Right. Yeah, exactly. And just those ideas about students and how it's different because when I was a trainee, we had an intern who this is in the same year who she was basically like doing things like repetitive checking sort of things, and I just remember like people kind of like just sort of she's like just talking about her in a sort of kind of way, but no one really thought about maybe she's not okay, right? It was only about there's like this idea like there's just something wrong with her, but maybe she's not okay. And it was only later, some months later, we learned that all details that basically she ended up having to like leave, right? And it's like, well, gosh, what if somebody would have checked in on her? That maybe she wasn't okay, but the culture just wasn't that way. It was like you got to be on top of things. You can't show sign of weakness, and so all those things sort of coalesce in that one moment. And so what's different now? I think again, I talk about students being more open to these conversations. I talk with the medicine program director, like how is it different than when I was a resident? We had a nice conversation about all the different steps they've been making. We've talked about how it's different, how it's better, and how we're sort of beginning to make progress. But it's a long road. You think about people like me. I'm 50. I just turned 50. Hard to me to acknowledge that, but yeah, I'm 50, and so it's what's the alternative, right? And so yeah, so and so I turned, and so I guess what I'm saying is that there's so many doctors out there in the world who've trained under this model, who are out there. So it's not like we're fighting against a lot of things that are still actually out there in practice. People who had that same experience, same perspective, and so I hope that in some ways, me telling my own kind of version of this can help some of them kind of maybe think about things a little bit differently, because our patients need it and we need it. I mean, think about all the things, the problems that doctors are having, the struggles that we face, and the more we sort of can be open and transparent about that, I think the better off all of us are going to be.
I think it's so courageous to share your own story, and that kids come here through a lot of suffering and through a lot of shame and some difficulty. Were you nervous? Story? I mean, you tell it with a compelling hypothesis too of this will help. What would it like to?
Yeah, I mean, I guess that's part of the process, right, doctor? Yeah, sort of like I'm, yeah, no, I'm just kidding. But yeah, and I think that's just part of the process of, it's hard, right? It's hard. It's not easy to sort of, but I think it's useful because, like, if I just, you read some books by doctors and they sort of make it seem like they're the greatest thing in the world and they've never done anything wrong and everything's just magical, and I think that's crap. And I also feel like it's inauthentic because I think if you could understand my own, look at that warning. I think you can understand my own limitations. I think it maybe helps you be open to acknowledging your own. If you can recognize that I'm not here to judge you and say that you're a bad this or bad that, but I'm struggling with this the same way you are, and maybe that'll make you more open to sort of acknowledge your own limitations and how you can do better, because that's really the objective. And so if the cost is me telling that story to you, it's actually kind of therapeutic, right? So I said, man, I felt kind of good to tell that story, because honestly, until I wrote that, I'd bottled that thing up for years. Because it's still like this moment. It was so terrible, my worst moment, where I feel like I'd failed, everybody. I even when I had a couple of days off, and I went back and I saw my parents, and I couldn't tell them because it was just such a sense of like failure. If I had told them that I had some sort of problem, they worked so hard to get me to this place, and I'm going to let them down. The struggles that they face, segregation, it kind of going on and on, right? And so it was really hard. And so I'm glad I've told it, though. I think it's hopefully some of you, can take something from that in your own experience and people that you know, and maybe you guys are further along in the journey than I am. But we're all work in progress. And so yeah, I think that's kind of how I feel about it. There's a cost to it, but ultimately I think it's hopefully for the better.
I'm glad you did. We got the 5-minute warning, Susan, before we turn to questions from the group.
Okay.
Do that. I love the title of the book. And to me, it's such a psychiatrist study. Tell us about.
Yeah, right. It's really weird. This might sound a little strange, but something about taking showers really kind of clears the mind. And it's like both times that both book titles have come after I've taken a shower. So I recommend showers for other reasons, exactly. But it's also the creative side. I think getting physical and mentally physical value to showers, but also mental value. And so yeah, it's been amazing to think about. So both types kind of came to me that way. And it's just this idea, like if the whole issue with when we talk about mental health and psychiatry, there's no labs, there's no MRI, there's no X-rays, you can't see it. So if you can't see it, it's not real. One of the challenges, of course, is that there's so many things in medicine. So many things in general medicine and in specialty medicine that also aren't nearly as like concrete as we would like them to be, or we claim them to be. I think that's also a reality that general medicine needs to face. Because I think part of the issue is that psychiatry is sort of tried to emulate that in some ways. I don't think that's always necessarily the best place for psychiatry to be headed. This idea that we have to be sort of, not that it's not important, but like there's other things as well. There's this unseen part, and maybe there's something worthwhile in that. And so there's a James Baldwin quote that I like, where it says, I'm going to butcher it like I kind of always do. But basically, the basic effect is that you can't change everything that is gosh, that's really bad. Everything that is faced can't be changed, but nothing can be changed until it's faced. I think that's the gist of it, right? Apologies, Mr. Baldwin. But I think I did the best I could do there. But I think the issue is that, yeah, so with this whole issue, we have to face the idea that we might wish that people didn't have mental illness. We may wish that people didn't struggle the way they did, or didn't have to struggle with alcohol and drugs. And we may wish that we had quantitative things that could sort of pinpoint, and maybe one day we'll get there, right? But in the meantime, people are suffering. We have to face that, right? And so it's like facing this unseen thing out there, right? Because it's real in the sense that, people are struggling, people are suffering. And so that's really kind of what it's all about. We can't change the fact that, going back to kind of the Baldwin's code, we can't change the fact that there are people with mental illness out there, people who are struggling always. There's going to be some that always, but we have to face the reality that it's there, and that there's a lot more, in a lot of ways we've kind of failed. In some ways, we failed our doctors, we failed patients, and we have to find a way to sort of move forward. And that's kind of what this is all about.
Thank you so much for telling us about it. I could continue to ask you questions, but I will not, because I know there are other people who have questions for you, but truly thank you for telling the story.
Thank you. Thank you. So I apologize to Julie. I had so many questions for you because I'm a psychiatrist when I ask questions, and I just got talking. You're really good at this. And so I just got talking and talking and talking, and I couldn't stop. Questions, yeah.
We don't have any questions in the chat.
This doc,
I wanted to support what you said. I just celebrated my 50th reunion from medical school class of 1973, so the 50-year-olds. That the whole trend has changed dramatically. And as a gastroenterologist who did a lot of work in functional bowel disorders, where psychiatry was paramount, and frequently patients would not accept the idea that there was any psychological component. And GI actually was, and in this particular geographic area with Drossman at UNC, really pushed that. He actually, after getting his GI fellowship, got a master's in medical psychology in order to be able to promote the idea that psychiatric disorders were so prominent, the psychiatric aspects were so prominent in many of our medical disorders. And so thank you for highlighting this, but I think the real problem being that we still have so much trouble getting the psychiatric in, even with our health plans.
Yes, yeah, exactly.
Now,
so many barriers.
I on a personal level have to deal with this all the time for family psychiatric illnesses, and it is an incredible mountain to climb to try to get it covered, even when you have a whole lot of money.
Right.
You still can't get services and can't get.
Yeah, I mean, those barriers reflect the things that I'm talking about. They reflect the us versus them, and the idea we don't see it as real. Those barriers, it's not just among doctors, it's among legislators, it's among policymakers, it's health insurance companies. It's all connected in that same sort of way. So just for those of you, that was Dr. Joanne Wilson. So gosh, so you graduated med school, and she's the second Black woman to attend Duke Medical School. I just want to give her a little shout out. Also the mom of a couple people in our department. Yes. 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 So there you go. We wanted. Yes.
Part of that is driven by some mental illness.
Yeah.
Also, Rich Weiner and I were classmates from medical school.
Pretty cool.
Story of with Rich. I was sitting at lunch with him once. We were 5 people from my class who stayed on too. And discussing the psychiatric history of one of my family members. And I said she's been diagnosed with schizophrenia, and I go through the whole history, but I said she went back to work and then she got problems again. And then Rich is, Rich. And he says, I don't think that's schizophrenia. I think she may be bipolar. And they've just seen her each time when she was manic. And that's why they made that diagnosis. And he said, I think you should get her reevaluated. And I called her psychiatrist over in Raleigh, and the younger psychiatrist goes, aha, I guess we don't have the whole history about all of this going back to work and getting all of her work history and owning a house and all this other sort of stuff without any psychiatric care in the interim.
Right.
So it was really fascinating.
Very cool.
That's the kind of thing that can happen.
Yeah. Thank you, Dr. Wilson, for the story. Very cool. Great to see you. Question back there, I see. Yeah, and your point is valid. You think rheumatology, you think any medical specialty in the overlap with psychiatry is there for sure. Yes, sir.
That was a really great interview, and I really look forward to reading your book. But I was thinking when you were talking about your path to psychiatry, and it made me think of a story of my own when I was training to become a psychiatrist, and seeing an episode of The Sopranos where Tony Soprano was having his son evaluated for ADHD, just totally ridiculed the whole process. Said, my son fidgets sometimes, but not a lot, and he doesn't have ADHD, and he forgets sometimes, and a lot, just, totally was incredibly dismissive. And I remember thinking at that time, what we need is objective markers. We need to be able to quantify these things, and that will move the unseen into the seen.
Right.
And what I've come to learn is that I was incredibly naive about how difficult it would be for our field to do that. But then the other part of my question for you is, I guess, was I also naive to think that having those measurements would really change things? My thought was, if we have objective measures that will get rid of stigma, that will get rid of people denying mental illness, and perhaps that was naive as well. I'm curious your thoughts on.
Yeah, kind of mixed. That's a great question. I wonder about that because I wonder if there's so many things I could say about it, but I guess I would just say, I do wonder, if we had a number, if you do and it says this thing, and this is depressed, this is not depressed. I just wonder, what that would. I don't know. I'm of two minds about that. I think it's in one way it sounds like, oh yeah, we could be like the rest of medicine, but in some ways the rest of medicine is also kind of not doing that great of a job in its own way. And I think sometimes we in this idea of trying to be like the rest of medicine, we lose sight of, they're struggling in all sorts of ways, and these numbers they're malleable. Even think about, I'm just going to if this is not the, even think about the numbers we use for diabetes, hypertension, high cholesterol. They've all changed over time, and it's like what was once disease is not disease. I mean, these things. I think it's really true. The numbers have changed since I was in medical school for all those different things. And so I wonder if it would be. I'm not saying we shouldn't do the research and we shouldn't try to seek. I'm not saying that at all. I would never say that here. I'm in the wrong place to say that. But I do think that, we will be missing something. We think that's going to just solve all the problems. I mean, I think it's still, these issues are still going to be persistent because there's this idea of how people because if you say someone's, I always wonder, if you say something is purely biological, whatever it is, does that mean that it may reduce stigma, but it may also kind of create its own stigma in different ways. Oh, well, there's something kind of biologically wrong with this person, and maybe I still don't want to be around this person. So I think we still have to think about these issues in a different way. It's important, but we also think that things can still kind of be used in the wrong way if we don't get to the bigger picture of why these things can impact all of us, and we have to be thinking about this in a broader way. So I hope that answers a little bit what you were saying. Yeah, but it's a great question.
We have a few questions in the chat, as well as a lot of kudos. The first question is, do you consider the cultural perspective while treating a patient?
I mean, yeah. I mean, to me, it's like you can't. Well, I guess the way I see it, I guess it's the kind of code I use. I mean, it's like, if you don't know the person's story, I mean, you really can't really get the care that's needed. I mean, it's like, I think you also have to know your own story too. That's why I think it's also an important piece of how do you care for someone? Yeah, I mean, absolutely. I mean, there's no. I think people might look at some of my interviews. I get all the things you need to get done, but my main objective in sort of seeing that person is like, how can I get this person to come back for the second visit, right? I mean, to me, that's like the most, like, 'cause I can have all the medical knowledge in the world. I can know that this person needs to do this. Like, I can know this is what actually needs to happen. But if I can't get the person to sort of actually come back and have some kind of connection, then that thing's not going to happen, or it's just going to be like worthless. And so I might spend the whole visit just like we can talk about whatever thing that's, that's, I mean, we're talking about things that aren't, life, sort of more outpatient setting. I may talk about whatever is really important to them from a cultural standpoint, family standpoint. That's extremely important. I mean, I don't know the exact thing about cultural, but I would just say that in general, yes, that's extremely important. There's no way, two ways around it.
Another question in the chat. What do you think of a consultative liaison fellowship program as an institutional response to the disconnect you've described today?
Okay, so am I going to, okay, so, okay. So a consultation program. Yeah, I think that's, I really enjoyed psych consults when I was a resident. That was one of the things I really enjoyed. I love the idea of being, again, interfacing with other doctors. Because I think we get so siloed, I think that just makes it worse for, not only for the patients, which is first and foremost, it makes it worse for us as doctors as well. We don't this idea we're like, we all started in the same spot, and we have so much more in common than differences. And I think we sort of focus on our differences. So I think it's really important, honestly, to have those sorts of things. I know there's logistical things that are beyond my scope. I like even the idea of not just the inpatient consult, but even like how do you get exposure to the outpatient sector? Because that's where most people actually live, right? And how do we get exposure to those settings? How do we get working with rheumatologists and oncologists and et cetera, endocrinologists, all these ologists? How do you get working with them? And I think that's also really important as well. So I would say yes. Again, not knowing all the logistics, I think it's a really important thing to do.
We may be able to squeeze one more quick question. Does anyone have any questions here?
Oh, no pressure. I'm kidding.
Yeah, thank you so much. Where does, in terms of medical education, thinking about social determinants of health and learning about that, is that part of facing the unseen? And how could that be a stronger part of medical school?
Oh, absolutely. I mean, that's you're talking about bread and butter now. I mean, that's like that's like the thing I've been talking about for a long time. There's no doubt that that's like extremely important when we're talking about the patients that we see, all the different aspects of socioeconomic status, race. You can go the whole spectrum, the history. Even knowing the history is so important. I'm working on a project now. It'll be coming out later. Looking at sort of like the history of Duke, this place. And there's even there's a story about a case where Duke denied care to a Black person, and the person had a really terrible outcome. But the idea is that this was 1950, which seems like a long time ago. But it's in the course of this project, we've actually interviewed this gentleman's daughter. So she's a 73-year-old woman, a Black woman, who could come into your clinic, into your ER anytime, any day. And would you know that history? Would you know the story of what her family has had? Would you know how that's impacted them if you don't think about it? So there's no doubt that those histories are so important, that perspective is so important. Part of the solution for a lot of the mental health, like one of the things, part of the solution to some of these challenges are beyond medicine, right? Some of the solutions are like, how do we think about, our healthcare system? How do we think about housing? There's so many different broader topics that we have to be thinking about if we're really going to solve these problems. So I'm focusing mostly on the education, medical school piece of it. It's obviously a much larger piece that politicians and society have to deal with. Absolutely. So.
On the note of so much work to do, thank you so much. This is absolutely wonderful.